Now we're going to be talking about pyloric stenosis. And pyloric stenosis results when the circular area of muscle that surrounds the pylorus, it hypertrophies, and it basically obstructs gastric emptying because it becomes very stenotic. There's a very, very small opening, as you can see in the picture on the right. You can see where the duodenum is here, stomach, and here's the pylorus. So, and then the pyloric stenosis is in here instead of being maybe 3 times the opening of that, 3 or 4, depending on how bad it hypertrophies. Then when the baby eats, you won't have that gastric emptying from the stomach. Usually, this happens more often in families that the mom or the dad may have had it. The baby's not born with it. The baby, it usually hypertrophies around the 4 to 8 weeks of age, and these are really, really fussy babies, and we'll get into the signs and symptoms in a minute. But usually, it occurs more often in male infants, and it's also associated higher in white infants than in African American or in Asian infants. So I thought that was kind of interesting. Heredity and family predisposition seem to increase that risk of pyloric stenosis as well. I can remember when my first son was born, being a pediatric nurse all those years, and I just knew that he had pyloric stenosis because the child, he really had GERD, and GERD really wasn't a disease of fashion back then. It was like he just ate too much, but he had one projectile vomiting, and I took him right away, and he was fine. He was gaining weight. He was, everything was fine with him. But when you have babies that have GERD, or mamas get real protective of their babies, and as we all know. So here's the signs and symptoms of a child with pyloric stenosis. As you can just see from the patho, they'll have progressive projectile vomiting, and it is forceful projectile vomiting to the point where you have to ask the parent, how far did it go? It just didn't seep out of the mouth. It projected out of the mouth. And this happens especially after eating. Sometimes you can, on palpation in the right upper quadrant, you have a firm olive-shaped mass that can be felt, and that's usually just before they eat. You can maybe feel that, and maybe just kind of putting the baby on your lap and having the head hang down just a little bit. Maybe you can feel it. Sometimes you can't feel it at all, and it's okay if you don't feel it, because a lot of times you don't. You also may see visible peristaltic waves from the left to the right upper quadrant immediately before the baby vomits. I saw, and I didn't include it on Blackboard, but I had seen one on YouTube, and that baby was just so malnourished, and that was the only way that you could see it, but it was just like a ball that went from the left side to the right side. These babies are dehydrated. They have absence of tears. You're going to note that. A weak cry, depressed fontanelle. Remember that anterior fontanelle has not closed, so we want to make sure that we assess that. A poor skin turgor, dry mucous membranes, and they can also develop metabolic alkalosis, and you're not going to be responsible for what the pH is going to be and all of that, but just know that these are very, very sick babies, and usually they come into the hospital, or if they haven't been diagnosed yet, with what they call failure to thrive, FTT, and we need to find out exactly what's going on with them when they come in with that, because that's just a preliminary diagnosis, and maybe because they haven't put on as much weight. It's usually 1 to 2 pounds per week, and they're just very irritable babies, very, very irritable. They're very hungry, very, very hungry. It's almost like a cardiac baby, that you'll see. But with this one, you're going to see that projectile vomiting, and that's very, very, that's a hallmark, sign of this disorder. So on our diagnostic assessment, we'll do that history of vomiting, those visible peristaltic waves, palpable pyloric mass, if you can see that. The doctor or the nurse practitioner will order an X-ray. Ultrasound is the gold standard. It's very non-invasive, and they may do a barium swallow, they may not. They may do an ABG, especially if this baby comes in and is severely dehydrated. We'll also look at our electrolytes. They usually have decreased serum potassium and sodium levels from vomiting and not being able to digest their formula correctly. Increased pH and sodium bicarb, and they'll have decreased chloride. Their indirect bilirubin may be elevated. Indirect just means that it hasn't gone to the liver yet to be processed and to be eliminated. So that may be or may not be elevated. It's not one of the key blood work that we look at. But we definitely look at our electrolytes with these babies. So if they come in, and usually, mamas are a lot more astute, I guess, than we used to be. But usually this can be done because surgery is the intervention for these babies. So they'll do a pylorotomy, and this is the incision of the pyloric muscle to release the obstruction. And it's usually done. It's done by laparoscopy. If the child comes in, though, and is severely dehydrated, they're going to manage the IV fluids and electrolyte replacement before they take this baby to surgery. They'll also put in an NG tube for stomach decompression, and that's really important to stop the vomiting, and that usually does stop it. So they'll have their NG tubes, maybe to gravity or to suction. And our pre- and post-op care is on page 437. You can read that. But basically, our post-op care is very, very important to follow the physician's orders, because when this baby comes back, he may or may not have an NG tube just to keep the stomach decompressed, maybe for about 12 to 24 hours, and then they'll start with and they usually have a very specific regimen of how they're going to be starting the fluids with these babies, and they'll start maybe with just some Pedialyte, and they'll be real specific of 15 mLs the first 30 minutes, see how the baby does. It's about monitoring that baby and making sure that the baby has no vomiting, that the baby has no fever, and the baby is gaining weight as the days go by and the baby's tolerating fluids. So that's real important for mamas to know that, and make sure that they know the feeding regimen when they go home. I think it used to be a little bit more regimented than it is maybe now, but at least every 6 hours, they should be fed and managed, and make sure that the parents follow up with their appointments. Very important. So in our nursing diagnosis, of course, we're going to have fluid and electrolyte deficit that's related to vomiting. It's usually that metabolic alkalosis. We're going to have it's a failure to thrive. I mean, these children are just they can be emaciated if it's left and nothing's been done about it. But I think parents now are a lot more astute about getting their children in, getting their babies in, and usually that 1 month visit is very, very important. And it's important as a nurse for you to elicit any problems with feeding, especially if you're a peds nurse and it's a new mama or even a third baby, so got to make sure that on the growth chart that they are increasing their weight to 1 to 2 pounds every week. Alteration in nutrition, less than body requirements related to that vomiting, and that's kind of self-explanatory there. I think it's, let me just look here. On evaluation, you want to just make sure, that the child has a good skin turgor. The fontanelle is flat, it's not bulging or it's not depressed. They have moist mucous membranes. Their urine-specific gravity is less than 1030. As you know, 1005 to 1030 is normal, and a sodium level within normal limits. That's important in their potassium. And make sure that the child's tolerating oral feedings without any vomiting, and make sure that the child's weight has returned to pre-illness level, and that usually should happen within a week. Make sure that the surgical site is clean, dry, and intact, and without any drainage or any redness. And can the parents explain the need for that surgery? And as you evaluate, can they explain the need for surgery and routine pre-op and post-op care, especially, on going home? And is the child calm? Is the child content? Is the child free from any pain? And make sure that you address that with the physician. If there's something when the baby goes home, or you think the baby's still in pain, that he or she may need something, and just kind of assess the family unit, and see how they're doing, and see how the stress of having a baby in surgery, for the very first 2 months of life is very, very stressful for our families. So, okay, so that does it for pyloric stenosis. Now we're going to be talking about Hirschsprung disease, which is also called megacolon. Hirschsprung disease is a result of an absence of ganglion cells in the rectum, and to varying degrees upward into the colon itself. It's a major cause of lower bowel obstruction in newborns. Disease is the result of embryonic failure of migration of the hindgut ganglion cells to the most caudal portion of the GI tract, the rectum. And the initiating factor in this failure is unknown. So the child is born with this. Okay? So Hirschsprung disease occurs in about 1 in 5,000 births, with a 4-to-1 male to female ratio, so boys have it more than girls. It has a strong hereditary component, and there's a higher incidence in children with Down syndrome. I thought that was very interesting. So as you can see from this picture, you see that, and especially in the picture on page 440, if you want to turn there in your book, because I think this pathophysiology is just really interesting. You can see that the large intestine is pictured. You'll see the megacolon, which just is enlargement of the colon, and that part of the colon that's enlarged is a colon that is very workable, that has peristalsis, that has that nerve intervention. It's the aganglionic part, the region that is distal to the megacolon, that does not have the nerve intervention that will that the child can have peristalsis with. So when you look at adequate peristalsis cannot occur in that affected colon, leading to that tonic contraction of the lumen, and this produces a functional bowel obstruction, that chronic constipation, and the passage of ribbon-like stools. So that's important. Ribbon-like stools with Hirschsprung disease, and you can kind of, if you can't remember it, you can just kind of look and say, okay, what is Hirschsprung disease? What's the megacolon? Okay, well, the stool is going to be like pushed from the megacolon into the distal rectum where the aganglionic region is, and then you'll just have these ribbon stools that come out because of the pressure from the amount of stools that are in the megacolon itself that's dilated with the feces and the gas. And you'll see that in that aganglionic region you have tonic contraction, inadequate peristalsis, which can lead to partial obstruction, chronic constipation, enlargement of the proximal section, and complete bowel obstruction, or maybe an enterocolitis can happen as well. So on our signs and symptoms, we'll have the cardinal sign is delayed or absence of meconium stool in the neonatal period. Very, very important. That's the cardinal sign. Any child who does not pass meconium within the first 24 hours and who is prone to constipation or stool infrequency in that first month of life is suspected of having Hirschsprung disease. Then the infant or the older child may exhibit signs of bowel obstruction, abdominal pain, distension, vomiting, and failure to thrive. But that chronic constipation beginning in the first month of life usually results in those pellet-like or ribbon-like stools that are very, very foul smelling. So that's important. A rectal exam reveals a very tight internal sphincter and the absence of stool. That's usually followed by an often explosive release of gas and feces related to the sudden but transient increase in that rectal size. Barium enema examination basically demonstrates an abrupt change in the size of colon from a distended ganglionic proximal portion to the contracted narrow appearance. So we'll see this big part of the colon, and then we'll see a very, very thin distal part of the colon. Significantly, the child has a hard time evacuating the barium after the exam, and that's significant in this type of disorder because of the aganglionic area and the megacolon. So most of that barium is going to sit up into the megacolon. We'll have the definitive diagnosis of this is usually made by some form of biopsy. So we may see this baby that comes in constipated since the neonatal period. We'll have those ribbon-like or pellet-like stools, malnutrition, abdominal pain, distension, and of course there'll be failure to thrive. They don't have enough nutrition just because they are very, very irritable from the megacolon itself. So in our diagnostic, I think we've gone over this already. They have that tight internal sphincter, the absence of stools, and usually if we do the rectal exam, it's followed by that very explosive release of gas and stool. Barium enema can be done, but know that the barium may be retained, and we'll have to get rid of that barium before surgery. Rectal biopsy is usually definitive, and basically what it tells us is that we don't have any ganglia cells, and that confirms the diagnosis of it. So we'll usually give stool softeners to relieve the constipation, rectal irrigation for mild to moderate aganglionic areas. But treatment for moderate to severe is usually our surgical intervention. The aganglionic portion of the intestine is usually removed in 2 steps, and they perform a temporary colostomy, and they let the part of the other intestine just kind of rest, and then they do usually a surgical repair later on, usually when the baby or the child weighs at least 18 to 20 pounds or 8 to 10 kilos. Then the colostomy is closed during that time. So Sometimes they'll also, because of the real tight internal anal sphincter, they'll give Botox injections to decrease that pressure, and rectal irrigations are sometimes used to remove the air in the stool, and may be needed to relieve some symptoms associated with enterocolitis if there is any, before surgery. So we want to make sure that we assess the child with Hirschsprung disease. We want to assess their stools. We want to assess them for malnutrition, abdominal distension, poor feeding, history of poor feeding. We want to check their bowel sounds, see if there's any abdominal distension, any frequency of vomiting, diarrhea, changes in that abdominal circumference, because as you can see from the picture, I think a couple slides back, you'll see abdominal distension from the megacolon. Our nursing diagnosis is constipation related to aganglionic bowel and inadequate peristalsis of that area. Impaired skin integrity can be related to the colostomy and surgical repair. We can have risk for deficient fluid volume or excess related to surgical preparation. Impaired skin integrity, as we talked about, risk for infection related to surgical repair, imbalanced nutrition, less than body requirements, acute pain, especially if they're going to have surgery related to surgical incisions, knowledge deficit of the parents, and anxiety of the parent as well. So we want to prepare the child and the family for surgery. So we need to monitor and record the patient's bowel elimination pattern. Sometimes they'll give isotonic saline enemas preoperatively until the return is clear. Usually they're isotonic in infants just because of the fluid and electrolytes in children. So make sure that you kind of remember that when that's a really good question on boards or on HESI questions, or maybe even ours. Anyway, isotonic saline enemas are important. They can go lightly, but usually that's administered in children older than 5. They can do Fleet's phosphosodas, but those are usually for children, older than 5 as well. After that bowel cleansing, we need to keep the child on NPO status until surgery. IV fluids are needed, and strict INO is important. We also want to make sure that we prevent infection. They usually order neomycin 1.0% solution, which is given by rectum or by stoma, depending, is administered preoperatively to sterilize the bowel for surgery. And a lot of times they'll give IV antibiotics as well. Usually we need to take their temperature, tympanic, temporal, oral, or axillary. We need to avoid any trauma to the rectal mucosa. Make sure that we check that surgical site for redness, swelling, any purulent drainage. If the child has a colostomy, make sure that you inspect that for any bleeding, impaired skin integrity. We want to monitor sites for redness, discharge, any presence of stool. Make sure that we do meticulous skin care of the abdomen, the perineum. Dressing changes are performed, to keep the incisions clean and dry. We want to maintain nutritional and hydration status. So post-operatively, the child is on NPO status until the bowel sounds return, and G-tube is usually to intermittent suction until peristalsis returns. So we want to make sure that we give them IV fluids until they, keep those IV fluids going until they tolerate, oral fluids. We want to make sure that we address pain in our patients that have had surgery, and especially our little kiddos. If it's a school-age child, they can usually have a PCA, and with infants, make sure that mama knows, that repositioning, back rubs, holding, rocking, massaging, their little backs, and make sure that if there is any irritability and fussing, that you notify the physician about that. Providing education and relieving anxiety is real important, especially in a pediatric setting, especially before the time of surgery and after surgery as well. And they may need to be taught how to do rectal irrigations, the family. So I think it's a time that we need to be really, really patient with our families, and especially if they have a colostomy after, and them knowing that it is going to be something that's temporary and it's not going to be there very long, but they need to be taught how to take care of that and when to report any kind of abnormality with it. So on evaluation, we basically want to make sure that the child is passing soft form stools without any retention, especially after the surgical correction. Make sure that the child tolerated the bowel cleansing without any signs or symptoms of any fluid or electrolyte imbalance. Make sure that the child is afebrile. Make sure the colostomy doesn't have any bleeding, or the skin around it doesn't have any skin breakdown. Make sure that our bowel sounds are active and present in all four quads. Make sure you assess for pain. Make sure that the parent can demonstrate all the procedures that's needed for home care, and make sure that you kind of talk to your parents about their feelings about the body change to their little one, and answer any of those questions that they have about it. Okay. Okay, now we're going to be talking about intussusception. And intussusception is an invagination of a section of the intestine into the distal bowel that causes a bowel obstruction. If you look at page 438, it has the pathophysiology of intussusception, and it basically, the bowel kind of telescopes inside the ascending colon, and it's usually where the cecum and the ileum kind of meet. And you can see where the appendix is on here, but that's usually the area that's involved. What will happen is during this having this obstruction will cause bleeding in that very, very characteristic current jelly stool. The blood vessels around that area become trapped between the layers of the intestines, and the blood flow decreases, which then causes edema and inflammation. And you can have strangulation of the bowel, which causes gangrene, causes sepsis, and shock and death if we don't take care of this really quick. So it is one of the most common causes of intestinal obstruction, especially in children between the ages of 3 months and 6 years. So we see pyloric stenosis, which is another type of obstruction, but we see that usually between 4 and 8 weeks of age. But this is about 3 months to 6 years. In young children, the cause of intussusception is unknown. Some of the contributory factors include maybe a pre-existing upper respiratory tract infection, or some other kind of viral infection. If it's seen later in older children, there may be a mass or maybe some anatomical defect. Intussusception generally affects the infants and young children, with about 80% of cases before the age of 2, and rarely, like I said before the age of 3 months. It is more commonly seen in boys than in girls, and children that have cystic fibrosis are at increased risk for intussusception. So here are some of the manifestations, or the classic signs and symptoms are the passage of that bloody stool called a currant jelly stool, and diarrhea, and that sausage-shaped abdominal mass that may be palpated. You're also this child is usually well nourished and without any other history of a GI problem. But what happens is you'll have those paroxysmal pains that comes and goes, that become more constant as time progresses during the first several hours, and then it can become a more constant severe pain, and the child may vomit at that time. Symptoms of shock and sepsis are present if the obstruction has lasted more than 12 to 24 hours. The child can be listless. Older children may have pain without any other symptoms. So fever, increased heart rate, changes in LOC. Children are wonderful to take care of because they don't come up with any signs or symptoms. It is what it is. You can always tell that a child is very, very sick by if the child's not playing, and the child is, children always play. If they're just laying around, they're listless, lethargic, that's just not normal. Those are signs and symptoms of dehydration, possibly shock, and possibly sepsis if this is longer than 12 to 24 hours. So our goal is basically to restore the bowel to its normal position and function. And basically we're going to be doing abdominal x-rays. They may show an abnormal gas pattern related to the bowel obstruction or a soft tissue mass. Ultrasound is used in identifying the location of the intussusception and the amount of edema that's in that area. And a definitive diagnosis. This is really a cool thing because we can do a definitive diagnosis can be made, and the treatment for this provides that simultaneously with a barium enema or an air enema examination. So if you can just imagine, if we had barium, we gave an enema, and it basically pulls that part of the intestine, and it pulls it down because of the weight of the barium, and it gets rid of the telescoping of the bowel. In our nursing diagnosis, we'll have ineffective tissue perfusion that's related to the GI bowel compression, and acute pain related to bowel obstruction and surgery. What you have to remember is hopefully this will fix the problem. If not, then we'll have to do a laparoscopic surgery. If the enema fails, to reduce the intussusception, and but usually the success rate states that it's 80 to 95% success rate when they do that, what they call the hydrostatic reduction with a barium enema or an isotonic saline or an air enema under ultrasound guidance. But if that fails, they have to take them to surgery immediately. So on our assessment, we are looking at a previously healthy infant who suddenly began crying, flexing the legs, in severe pain. The problem may resolve only to reoccur a short time later, and then it becomes more constant as the child gets worse. So the nurse should assess any child for a bowel obstruction with signs of vomiting, nausea, abdominal distension, hypoactive or hyperactive bowel sounds, that palpable abdominal mass, that passage of currant jelly stool will confirm the diagnosis. So it's very important that we be astute on looking at the stools and asking the parent exactly what they look like. Make sure that you assess hydration. You assess for fever, any increased heart rate, that that decreased LOC that we talked about before, blood pressure, respiratory distress, all of those should be reported immediately to the physician. That's very important. So post-operatively, when we want to make sure that we keep the patient NPO until the bowel function returns. Sometimes they'll have to have an intermittent NG tube suction, IV therapy, pain, just depending if they've had to have surgery or if they've just had the barium enema that has reduced the telescoping. So this is very, very frightful for patients because these little ones get sick very, very quickly. But we can help them. You know, we just have to be real astute and make sure that we report any signs or symptoms of sepsis or shock on these little ones. Okay, the next one we're going to go over in this slide series is volvulus. And volvulus is a condition that's caused by malrotation or twisting of the bowel that results in a bowel obstruction. And it usually is the result of a defect in fetal development. It's the midgut, which normally rotates about 270 degrees around the superior mesenteric artery, which fails to rotate and fix itself to the abdominal wall. So affected infants usually manifest pain. They'll have bilious vomiting, and so that's the difference between when you're going to see the pyloric stenosis and intussusception. So they'll have bilious vomiting, whereas our pyloric stenosis patients, remember that they the stomach contents has not been digested, so we have undigested formula, whereas with this infant we'll have bilious vomiting. Okay, so I want you to make sure that you kind of have a working knowledge of that. They'll have other signs also of bowel obstruction that we've talked about before. Surgery is essential to prevent the bowel ischemia, and the nursing care is similar to that with intussusception afterwards. Just making sure that there's no fever. We're monitoring their weight, their INO, looking for any vomiting. Probably have an NG tube in to suction. Listen for bowel sounds. Slowly we'll introduce fluids again for them. So just review the post-op care for intussusception, and it's basically the same. So, but the signs, the symptoms, or all these obstructions are going to be a little bit different, and we'll see that also in Hirschsprung disease that we'll talk about next. Okay, thanks.